This is Patricia Walter with the Surface Hippie Info website, and I'm in Columbia, or South Carolina, with Dr. Gross.
Hello, Pat. How are you doing today?
Good, thank you. Dr. Gross has done over 3,000 hip resurfacings, and we would like to discuss why a patient should choose a very experienced hip resurfacing surgeon to do their resurfacing surgery.
Well, Pat, that's almost obvious to ask that question. Like anything in life that's complicated to do, someone who's done more of them is going to tend to be better. So certainly someone who's done a lot of resurfacings could be a very poor technician and do a bad job. But in general, with anything intricate in life, if you do more of them, you're going to get better at doing them, right? And so then it comes down to what are the results actually. And I think it's also important to look at posted results. Everyone can claim they can do a good job at something and say, oh yeah, the average expected results are this and this and this, but what about actually putting numbers out? If you go to my website, you can see the actual numbers of failures and complications, and you can see that the risk of hip resurfacing is very low in the hands of someone who's done a lot of these. And I'm not the only one. There's plenty of other good hip resurfacing surgeons who've done large numbers and have become very good at doing this. It is a very complicated operation to do. It's not very closely related to hip replacement. It's an operation on a hip. There's also hip arthroscopy. There are also hip osteotomies. Those are totally different operations. I don't do those. I'm not good at them. And if I tried to do those, I wouldn't do too well at first. And I'd have to do a lot of them to get good. There are plenty of surgeons who are experienced at those operations who do them very well. If I have patients who need that, I send them there across the country, because these are very technically demanding hip operations that really require someone who dedicates their career to do this very well. And let me point out something that has become very controversial just recently. There was an article published on the British registry results of hip resurfacing recently in the Lancet article, and it made all the media, and it basically said that the results for hip resurfacing are not as good as for a cemented 28 millimeter total hip at 5 years across England and Wales in their hip registry study. And this really highlights this point, because the conclusions drawn in that article, I think, were improper. And I really fault the editorial board of Lancet for not taking a more critical look at that paper, because it just took me one read of that paper to just crunch the numbers. There were 26,000 resurfacings done by about 800 surgeons. We did the math over 8 years. It came out to 4 hip resurfacing surgeons on average per year. Now I do 400 plus a year. It doesn't require 400 plus a year to be good at this, but it takes a lot more than 4 a year to be good at this. So what the Lancet article really pointed out is what kind of results you can expect from surgeons who on occasion do a hip resurfacing. That's what that is, 4 a year. That's an occasional hip resurfacing. That's someone who's dabbling in hip resurfacing. That's not anyone who I would go to have my operation. But that's what the Lancet has shown. These are the results, and they're not as good. Yes, people who do 4 hip resurfacing operations a year would probably do better putting in just standard 28 millimeter cemented total hip. They'd probably have better results. I agree with those findings of the Lancet. But to come out and damn hip resurfacing based on that data is absurd to me. So let me just throw out my comparative data. So the Lancet article had an approximately 80% capture rate of patients in England. So that's a very poor follow-up rate, 80%, particularly for a national registry. I would hope that they could do better. My follow-up rate in my private practice from patients coming all across the country is 92%. So the level of accuracy of my data is better. And we have 5-year survivorship data to compare to the Lancet article in all comers. And I don't select hip resurfacing. I don't exclude people who have smaller implant sizes, who have fairly damaged femoral heads. I think they all can be done. And at very low risk, and my data proves it. Because overall my survivorship at 5 years is over 98%. Okay, so that beats the 28 millimeter total hip, and it beats the resurfacing by far in the Lancet article. And if I break it down between men and women, the survivorship for men is better. We all know that resurfacing has lower complications in men, about 99% survivorship in men at 5 years, and about 96% in women. So women are the challenge, and we're working on trying to bring that up. We've already improving the results in women, but we need to continue to work on that. Not abandon women. Young women who want to be athletically active need a resurfacing also, and the challenge is to make it better. And the results are showing that year by year we're getting better, and we're getting closer and closer to men with women. But that just shows you the failure rate in the British registry was 2.8% for the total hip replacement, and we're below 2% for resurfacing at 5 years. So that just shows you the difference between what surgeons who dabble in resurfacing can do and what someone who has experience can do.
So basically, the experienced surgeon places the acetabular cup perhaps better. They understand, what angles it needs to be at, and also the femur portion. Are these the two intricate parts that make the surgery so difficult?
Pat, there's a lot of intricacies to it. I would say you've hit it there on the acetabular component. That is the most critical part of the operation. We didn't recognize that for the first, 5 to 7 years I was doing this operation. We had no clue that the acetabular component, that's a socket, the acetabular component placement was so critical. Koen de Smet was really the first to make us aware of that and start the process of understanding how critical that is. But we've learned a lot in the last 5 years about that. And yes, placing the acetabular component properly is the most difficult thing, and is the key to avoiding at least the adverse wear problems. If you place it right, adverse wear problems don't happen. These are not allergy problems. These are excess metal debris in the joint from a cup that's too steep. When the cup is too steep, the ball rides more on the edge. It's called edge loading, and it produces a lot more metal debris. So if you place the cup in a more horizontal position, particularly the smaller implants, that's where it's really critical. That's how you avoid the wear problems. And it's very possible to do that. We've developed intraoperative x-ray techniques where we can be within 5 degrees of accuracy of placing that cup exactly where we want it on the standing position after surgery. So it's very doable, and yes, the socket component is the most critical. There's many other parts of the operation. You don't want to strip the tissue off the neck so much. You want to do a very careful dissection of the muscles so you don't damage the muscles. It's a difficult operation to do. So there's many aspects that are difficult, but the socket placement is probably the most difficult part.
Well, that's true for athletes and musicians and any type of activity. You can't beat going to an experienced person.
That's correct.
Yeah. Thank you very much. I appreciate your information.
Thanks very much, Pat.